This video is to introduce a method for the evaluation and the treatment of patellar dislocation. The detailed inquiry of the dislocation events is very important for the evaluation. The swelling and pain of the involved leg joint are the main complaints of patients. The following information should be recorded. The assessment of patients should begin with the evaluation of varus and valgus. A positive J sign indicates the maltracking of the patellar. Batten scores can be calculated to assess generalized ligamentous laxity. Other physical examination in this picture are easy to conduct. The imaging evaluation of patellar dislocation mainly includes three parts. The first part is the radiograph. A standard standing long-leg anterior-posterior radiograph should be made to evaluate coronal malalignment. The true lateral graph is needed to evaluate the patellar aorta. Axial radiographs are essential to evaluate the trochlear depth in the patellar tract. CT scans can provide pieces of evidence for surgical indications. The femoral anteversion and the tibial torsion should be measured using CT. Tibia tubercle trochlear groove distance should be measured in this modality. This measurement may be hard to measure in patients with trochlear dysplasia. In this condition, TTRA distance can be the substitution of TTTG distance for the assessment of tibial tubercle position. The value of patellar tilt more than 20 degrees is evidence for lateral retinaculum contracture. In this condition, the lateral retinaculum release should be considered. The status of MPFL, meniscus, and the cartilage of leg joint should be evaluated using MRI. The methodology of the trochanea was divided into normal trochanea, low-grade dysplasia, and high-grade dysplasia. The TTPCL distance can be measured in this modality to evaluate the relative position of the tubal tubercle. 26 mm is the pathological threshold of excessive TTPCL distance. Patients with first-time patellar dislocation in the absence of the loose body and osteochondral fragment can be treated non-surgically. However, for patients with multiple anatomic risk factors, recurrent patellar dislocation may still occur after isolated conservative treatment. The purpose of surgical treatments is to restore the normal anatomic structure of the patellar femoral joint and obtain a favorable patellar tract. Repair or reconstruction of MPFL was routinely performed to enforce the medial constraint. The lateral retinaculum release should be considered when patient with lateral retinaculum contracture. TTTG distance more than 20 mm or CDI more than 1.2 are the indications for the TTO procedure. For patients with femoral anteversion more than 30 degrees, the rotational femoral osteotomy should be performed to correct the excessive rotational deformity. Patients with high-grade trochlear dysplasia can be chosen to perform trochleoplasty. The indications for these procedures were presented in this table.